All right, lactose intolerance. Oh, I feel bad for these people. Ice cream, ice cream, ice cream. That's about it. If I had to give up ice cream, I would give it up, but not happily. All right, so this is a low lactase level preventing adequate breakdown of the disaccharide lactose. Right. Colon bacteria then get a hold of it, and they produce gaseous byproducts, which is socially as well as abdominally uncomfortable. Bloating, flatulence, abdominal discomfort. A lot of this really depends on your genetics.
Right,
The British have the lowest predisposition of this across the world, lower trends in the European population. As we look at the Eastern and Central Asian populations, Native American populations, it can skyrocket to 90 plus.
Yeah, striking.
Just not fun. And the problem is, if we look at that lactase production individually as we age, our lactase production drops. And so what you could tolerate, that latte, that triple cone that you loved as a teenager to a 20-something, 40, 50, 60, 70, you're getting much more pain with it. That's just sad. So it's not bad enough that you're getting older, but now you can't enjoy some of the good stuff. All right, what do? Well, if you're lactose intolerant, you avoid lactose.
There you go.
Thankfully, we do have lactase enzymes. So we've got lactate, and you can either take it in a pill form that you put into you, or you can purchase something that actually has the enzyme in it. Lactate milk, lactate ice cream has the lactase in it. Flip side of that is, since these people are avoiding a lot of dairy, just got to make sure that they've got adequate calcium and vitamin D intake.
Good point.
Don't forget that. As if we could forget vitamin D. Vitamin D is all over the place in the news these days. All right. And now we come to the end of things. Rectal issues.
Oh.
You know what? Hemorrhoids are just a lot of fun. Nothing like having a patient bend over and display hemorrhoids for you. These are dilated veins in the perianal region, as we all know. Common with constipation, pregnancy, even easy pregnancies will leave you the gift that keeps on giving. The external hemorrhoids are the old school itching, burning. I feel this lump when I wipe, doc, and you can see them. As I'm fond of saying, that's when you drop the H-bomb, preparation H. If they haven't tried it, go get some. Internally, usually this presents more with painless bright red blood per rectum. They may notice some bright red blood when they're wiping. Occasionally you'll get a prolapse of one of those, but doesn't tend to have kind of that itching and burning that's classic with those external hemorrhoids. Typically not visualized in external exam, and cue the anoscope. Here we go. Anoscope. Nothing more fun. When I show students coming through my office the anoscope, they're like, "When did you start practicing? That looks medieval." Yes, it is. But it gets the job done.
It does.
How do we treat these? If it's external, good old-fashioned Sitz baths, some preparation H just to vasoconstrict down a little bit. There's also mild potency steroids that you can use to kind of shut down some of that inflammation, give some symptomatic relief. We can always surgically excise these, but I can't imagine that the healing on that is good.
Yeah.
Oh, to sit down for quite some time is not comfortable. Internally, we have hydrocortisone in suppository form. You can put a little bullet of it up there. Also, we've got rubber band ligature, which is actually kind of amazing because you don't have much in the way of nerve endings there. It's painless. And people are going in going, wait, you're going to do what to me? It's not really going to hurt. Wow. Obviously, they can also be surgically excised. Ounce of prevention is worth a pound to cure. High fiber diet, stool softeners, more water, hit the fruits and veggies.
There you go.
Fecal impaction. I touched on this a little bit earlier. This is concretion of stool, packing the rectum and actually usually probably extending into the descending colon. They actually now have impaction-specific devices, so it's not just Nurse Ratchet and a whole lot of fun. You can also break these down with enemas, but now a lot of, as it's becoming more widely available and we have the internet, there's a lot of these devices that you can actually go up and you can actually do a form of enema, or at least an injection, while mechanically breaking down the fecal impaction. Again, just be patient with this because this can take a while.
It does.
Anticipation. It will be better. You can also follow that kind of with, once you've kind of cleared from below, never a bad idea to kind of follow with kind of an oral lavage, electrolyte solutions along the lines of like a colonoscopic prep, an osmotic laxative to kind of get everything flushed out and kind of reacquaint the colon with normal peristaltic motion. Dietary changes and talking about the reasons why this fecal impaction began in the first place. Never a bad idea. And is there something else going on? Is there something else that you don't know about at home that may be setting all this up? Get them to exercise more. Never a bad idea across the board. And also, again, take advantage of the body's natural desire to defecate after we eat. So sit on the toilet after meals, just like my little itty bitties were to try and get them potty trained. If you're having trouble with impactions, you always run the risk of an anal fissure. And this is just a linear tear in the anal mucosa. You can imagine that this could be very, very painful. You're basically just going, it's nails on a chalkboard, except it's stool on an anus. And you're basically just tearing through the lining. You can also get an extension actually all the way through the mucosa down to the muscle layer. Obviously, that's going to be it's going to take a little bit longer to heal on that. Right. Very firm bowel movement, or that tortilla chip we talked about earlier that didn't digest, that just wants to go scrape down the side.
Ouch.
Problem is now once you've got a fissure, it complicates itself by actually causing some anal muscular hypertrophy. And so it kind of becomes this
vicious cycle,
and it maintains itself. So you need to do things to try and relax that sphincter tone. You need to do things to make the stool as soft as possible so that the body is not squeezing in response to that pain. Right. Because otherwise that's kind of self-induced. Well, it hurts if I poop, so I'm not going to poop. Especially with kids. Adults, you can kind of talk them through it a little bit more and say, hey, you're going to have to tough through this, man. You got this. But with kids, they'll just hold it forever.
They just can't deal with the pain.
We have to make it so it's not painful so that they will not hold excessively. Most people are going to notice that they get a little bit of bright red blood when they wipe, and typically it's going to be posterior midline or anterior midline, but almost always it's going to be posterior midline. If it's elsewhere, you actually really do need to, particularly in kids, have to have the red flag go up, like there may be actually some molestation going on. So just be aware of that. But it should be either at the 12 or the 6 o'clock position. Usually at the 6 o'clock as you're looking with them bent over. Right. How do you fix it? Soften the stool, more fiber, more water. Sitz baths can be helpful. Pretty rare that it goes to the surgical consult state, but if it's not getting better, your colorectal colleagues will have something to say about that. All right. And perianal abscesses. Always fun. These are going to be kind of an extension of bacteria from the anal glands along the dentate line, and they can go on vacation near or far. They can just stay perianal, or they can go all the way up to supralevator, as we've got the list there. You get a little bit of debris obstruction, causes a little bit of bacteria to get there. They enjoy the time there. They start to grow and replicate, and then you can extend deeper into the tissue from there. Right. And not uncommon to develop a fistula from an abscess, because your body is naturally trying to find a way to get rid of this
path of least resistance.
And if it can make another one that's easier and less resistance, it will find a way. All right. So frequently this is obstruction of those glands. Occasionally you can have inflammation from something like a Crohn's, trauma to the area, malignancies, sexually transmitted infections, things of that nature. Men much more common than women. Go guys, 20 to 40 age range is usually when we'll see them, although they can be on either side of that. Okay. What do you think it's going to feel like?
Oh, not good.
It can't be good. So it's a deep, dull pain. If you've ever had an abscess, which I hope you haven't, you just get kind of this stretching. You get all the inflammation that comes with it, this immune response. The tissue is just severely, severely sensitive. Imagine having to pass a bowel movement past there. No good. So sitting, defecating will obviously really, really crank it up. The higher the abscess, the more cephalad the abscess, they can kind of go a little bit longer.
Yeah.
Because you're not at that pinch point, so to speak. And so as you go up a little bit higher, it can kind of push out of the way a little bit easier. Right. A little bit more space around it. And so those people can actually present a little bit more systemically ill because it has a chance to extend versus the, ooh, gosh, that hurt me right away. If it hurts right away, you usually do something about it. So what are you going to see on exam? How do you work it up? Typically, it's going to be just what you would expect with an abscess, an erythematous fluctuant mass near the anus. The higher they are, the more likely you are to miss them. So it's that 10% that might be missed on a digital rectal exam. Patient's not going to be real happy while you're doing the exam either. So pain out of proportion to what they should have for a rectal. To kind of get an idea of how far may this have extended, CT and MRI can be useful. You can also do a DRE under anesthesia, but realistically at that point, rather than putting somebody in anesthesia, I'm just going to get the scan.
Right. Makes sense.
And again, look at the fistula formation. Somewhere around half of the cases can develop a fistula. And again, that's just the body's way of saying, I need to get this out of me. I want to drain on my own. If you're not going to drain me with a scalpel or something else,
I'll find my own way.
I will find my own route.
Yeah.
Thank you very much. So this is the time where the colorectal, they shine. Incision and drainage is the key. Like most abscesses, frequently we'll put antibiotics on board, but realistically, it's about drainage.
Right.
It's about drainage. Get the pus out. Get a tract for things to drain so that we don't develop a fistula. So, if someone is septic, you need to be on antibiotics. If there's extensive spread and cellulitis, they need to be on antibiotics. Or if they have other conditions that would put them at risk, some sort of immunosuppressive condition like a diabetes
Sure.
or other immunosuppression, heart valve anomalies, prostheses, anything that we would normally give antibiotic prophylaxis for anyway. As far as coverage goes, Vanco and trimethoprim sulfamethoxazole or Bactrim are a good choice, given the fact that we're seeing more and more culture-positive MRSAs out there. And again, this is where they're going to follow up closely, probably not with you if you're in primary care, but with the colorectal surgeon looking for fistula formation. Because again, if half the people are going to develop it, we want to be proactive in looking for those and follow up. All right, rectal cancers. Rectal cancers are highly tied in with human papillomavirus infection. Increased risk if you have multiple partners, anal intercourse, and men who have sex with men. In fact, a lot of clinics are actually doing anal paps, looking for that HPV because that is obviously a big risk factor.
Sure.
And going forward, over time, it does lead to pretty high risk. Typically, this is something that's kind of slower going, though. You don't tend to see this in younger patients, but over age 50. Not uncommon to have in conjunction with an anal fistula, tobacco use, again with the tobacco,
there we go.
or other conditions that cause that immunodeficiency and suppression. All right, so how's this going to present? Rectal bleeding, change in the bowel habits, occult bleeding. I don't typically do an occult in the office anymore after the digital rectal studies have shown that that's really not very useful as far as picking up occult blood. Better to send them home with a Guaiac card and get a truly random sample. You can get abdominal pain with extension, and you actually may get localized spread and or mass effect with urinary symptoms and or low back symptoms. All right, how do you diagnose it? Digital rectal exam. If you've got short fingers like me, you might have to go to the proctoscopy. Lymph nodes, so checking those inguinal lymph nodes to see is there something else going on. And that may even be a presenting symptom if they haven't had any of the others.
Okay.
We're going to be looking to see is there anything else going on? Are we getting any anemia with this? Chemistry panel. And then, as is typical for anything in that gut, CEA and the CA19-9 are useful for following up as we go. And I have seen people order those, even though it's not a screening test. If those numbers are through the roof, get the scan, have a high index of suspicion. Biopsy is going to be your key, staging again with CT of chest, abdomen, pelvis, because that is going to determine where you're going with this. Localized, obviously, we will be doing surgical resection. Chemotherapy, kind of plus minus on that. If it's systemic, we're probably not doing surgery. Again, just the chemotherapy. That's kind of a good general rule across the board. And then a localized radiation and or radiation for metastases that are symptomatic. And again, since there's a high correlation with the human papillomavirus, the HPV vaccine, looking down the road, hopefully we'll see these levels start to decline as we're doing a better job of vaccinating these populations in their youth before they have a chance.
All right. Wraps it up.
Woohoo.